bathing or dressing or fixing a meal. They do not sleep soundly, and they do not awaken feeling refreshed. They may have daily sore throats, swollen lymph glands, and headache, and many experience excessive sensitivity to light, to sound, to temperature, odors, and medications. They may be overly vigilant due to an overactive sympathetic nervous system. As a result, they are nervous, anxious, like an animal that has been frightened and frightened and frightened again. It is no surprise that such individuals would present with 20 or more symptoms. They are complex and very challenging, but they are like a person who is drowning, and it's the job of the physician to throw a life preserver to help this patient. Such individuals also impose a tremendous economic burden on the Japanese nation. Based on data from the United States, this illness could account for 14 billion yen in total annual healthcare expenditures in Japan, and 37 billion yen of lost productivity. Today I'm going to focus on 5 areas. First, the signs and symptoms of chronic fatigue syndrome. Second, the evidence that chronic fatigue syndrome is a real illness. Third, the evidence that chronic fatigue syndrome is not due to depression. Fourth, the American approach to management. And lastly, pediatric chronic fatigue syndrome. My approach to managing CFS may differ significantly from the approach currently taken in Japan, but it's my humble hope that the treatments that we have found effective in the United States will be of great benefit to you in Japan. And I hope that my presentation will not only provide a framework for CFS sufferers to follow, but that Japanese physicians will also benefit from this approach.
今スライドがなかったところですけれど、これからですね、翻訳についてはスライドの番号とそれから皆さんのスクリーンの左下の番号が一致してますので、これを見てご覧ください。
So let's talk about evidence that chronic fatigue syndrome is a real illness. Brain abnormalities. MRI scans show high-intensity white spots here in 80% of cases. SPECT scans over here show decreased blood flow in specific areas of the brain, especially the midbrain and the temporal lobes. And neuropsychiatric testing confirms problems with attention, memory, and processing speed. The autonomic nervous system. Abnormalities of the sympathetic and parasympathetic nervous system are common, including tachycardia, which is a fast heart rate, orthostatic intolerance or fainting in up to 100% of subjects, and low plasma volume and red blood cell mass. Patients tend to have a very rapid heart rate. Patients have a very rapid heart rate, a low blood pressure, and syncope or fainting. Sleep disruption. Sleep is markedly disturbed in up to 62.5% of patients. Evaluation in the sleep laboratory frequently reveals sleep apnea, sleepwalking, narcolepsy, or upper airway resistance. The hypothalamic pituitary adrenal axis. The HPA axis has abnormalities in the midbrain that cause suppression of the hypothalamus, which is right here. This in turn suppresses the pituitary gland, which is right here in the middle of the brain. The pituitary gland controls all of the other glands in the body, including the thyroid, the adrenal gland, and the gonads, or sexual glands. Thus, in many patients, there is a low cortisol and DHEA, low thyroid, thus many patients have a low cortisol level. They would have low thyroid levels, and low estrogen or testosterone, with a loss of libido and early menopause in the ladies. The immune system is affected in chronic fatigue syndrome as well. This is manifested by cytotoxic T cells, poorly functioning natural killer cells, upregulation of the enzyme system 2,5-A and RNase L, increased inflammatory cytokines, and reduced levels of gamma globulin, which are your antibodies. As a result, we see a reactivation of old viral infections, autoantibodies, inability to fend off viral and fungal infections, recurrent staphylococcal and streptococcal infections, influenza symptoms, and fevers. Genetics. Twin studies and the study of family histories has demonstrated that certain human leukocyte antigens are inherited, such as these here. The risk of a descendant developing chronic fatigue syndrome ranges from 2.7 times normal for children to 2.34 for the next level of relative, and 2 or 2.03 for a third-degree relative. Several gene variants are present in persons with chronic fatigue syndrome that control neurotransmitters or brain chemicals that control tryptophan, TPH2, COMT, which is the serotonin gene, and NR3C1, which is the glucocorticoid gene. These genes control mood, they affect sleep, motivation, body development, and metabolism, which explains many of the symptoms that we see in chronic fatigue syndrome. Oxidative stress and energy metabolism. LDL, that's the LDL cholesterol, the so-called bad cholesterol, is increased where the good cholesterol is decreased in persons with chronic fatigue syndrome. And this oxidative stress is increased in patients with CFS as compared with the normal population. Cellular energy, which is measured by ATP, is reduced in persons with chronic fatigue syndrome. This explains why persons with CFS have very low energy levels, poor stamina, and malaise after minimal exertion. These graphs demonstrate that moderate exercise increases mRNA expression for sensory adrenergic immune genes in chronic fatigue syndrome patients, but not in normals. These are the patients. These are the normals. Each color represents a different mRNA. You can see that the patients have much more mRNA after exercise than normal control patients do. Dr. Lapp at the University of Utah measured the production of mRNA by genes in controls and patients. So each one of these colors represents a different mRNA, and each cluster represents a period of time after exercise. You can see clusters of data for 30 minutes after exercise, 8 hours after exercise, a day after exercise, and 2 days after exercise. It's clear that persons with chronic fatigue syndrome in the lower graph produce more mRNA than the controls in the upper graph. Using these gene expression studies, it's possible to distinguish normal individuals from persons with chronic fatigue syndrome, discriminate chronic fatigue syndrome from FM or fibromyalgia, to determine the severity of the chronic fatigue syndrome, and even predict who will have orthostatic intolerance. This technology shows real promise as a marker for persons with ME/CFS or FM. post-infectious ME. 75%, sometimes 85% of cases occur abruptly following a viral or flu-like illness. 2 studies validate that common infections can trigger chronic fatigue syndrome. In 2006, an Australian study followed individuals who contracted mononucleosis, or EBV, Q fever, or Ross River fever. While most recovered from these illnesses at 1 year, 11% still had the symptoms of chronic fatigue syndrome. CFS did not develop more frequently in persons with a history of psychiatric illness, which suggests again that depression occurs as a result of CFS and does not cause the chronic fatigue syndrome. A more recent study done in Miami of 300 adolescents who contracted mononucleosis showed that at 12 months, 7% of the patients met criteria for chronic fatigue syndrome, which is consistent with the Dubbo study. And at 24 months, 4% of the adolescents still had signs and symptoms of chronic fatigue syndrome. Next, I would like to dispel the myth that chronic fatigue syndrome is caused by depression. Epidemiology, symptoms, course of illness, medical fact all support that chronic fatigue syndrome is not caused by or due to depression. First, depression usually develops insidiously, while 75 to 85% of cases with chronic fatigue syndrome occur abruptly. CFS occasionally occurs in clusters or populations of patients. Small epidemics have been reported in England, the United States, Iceland, New Zealand, and many areas throughout the world. On the other hand, depression occurs in individuals, not in groups. Medical therapy. Antidepressants can significantly improve depression, but they are seldom helpful in chronic fatigue syndrome. Likewise, exercise improves depression, but it worsens chronic fatigue syndrome, something that we'll talk a little bit about later. Symptoms. Many symptoms of chronic fatigue syndrome overlap with those of depression, particularly sleepiness, fatigue, and discomfort or pain. However, these symptoms are much more severe in chronic fatigue syndrome. In some symptoms, such as fever and headache and post-exertional malaise, they're much more common in chronic fatigue syndrome, but are not typical at all of depression. And lastly, the outlook, which is probably the most obvious distinction between depression and chronic fatigue syndrome. And that is that depressed persons are hopeless and helpless and withdrawn. But on the other hand, persons with CFS tend to be proactive, they seek medical care, and they're politically active, as this group is today. Like all of you. Like all of you. Lastly, biological evidence is enlisted against depression as well. This can be found again in the HPA axis. Remember, the hypothalamus controls the pituitary, controls the endocrine glands. And when adrenal function is studied, this is adrenal function here, cortisol is increased in depression, and CRH is increased in depression, whereas in chronic fatigue syndrome, it's the exact opposite. Cortisol is decreased, and CRH is decreased. Let's turn now to the 4 cardinal symptoms of chronic fatigue syndrome and the management of CFS. There are no tests that diagnose CFS, so we must rely on symptoms or a clinical case definition. The 4 core or cardinal symptoms of CFS are pain, cognitive difficulties or trouble with thinking, fatigue, and non-restorative sleep. By non-restorative sleep, I mean that sleep is very shallow, and no matter how much sleep a patient gets, he or she will still awaken feeling very tired and stiff and foggy. In addition to the 4 core symptoms, persons with CFS are 7 to 9 times more likely to have comorbidities or overlap syndromes. The most common overlap syndromes are irritable bowel, an irritable bladder, migraine, dry eyes or dry mouth, and orthostatic intolerance, and sacroiliac or low back pain. From an epidemiological standpoint, there is no known cause for chronic fatigue syndrome, but triggers have been identified. In about 85% of cases, the trigger is a viral or a flu-like illness. Long-term studies in the United States show that a majority of persons with chronic fatigue syndrome improve over time, that is months to years, and neither CFS or FM are degenerative illnesses, so patients generally do not get worse over time. To help understand chronic fatigue syndrome, I frequently refer to the CFS triangle: sleep, pain, and fatigue. These 3 symptoms are interrelated. For example, if you have pain, it's difficult to sleep, and pain is exhausting. So if you have pain, it's difficult to sleep, and pain is exhausting. There are few treatments for fatigue, but we can treat sleep, and we can treat pain. Fatigue tends to improve as these 2 are treated. So how do we manage sleep problems? To manage sleep, it's first important to have good sleep habits. For example, use the bed only for sleeping. Go to bed when sleepy and never try to make yourself sleep. Hide the clock from view so that the time of night does not cause anxiety. Don't be afraid of insomnia. Quiet rest is almost as good as sleep. Keep a regular schedule and set an alarm and get up at the same time every morning. These have all been shown to be helpful in studies that we've done at Duke University where I practice. When good sleep habits alone are not sufficient, then simple sleep aids might be helpful, such as melatonin or antihistamine. The next step would be to use patented sleep medications such as azapapone, Zaloplan, or Ramelteon. If sleep is not improved with these simple therapies, it's very important to consult a sleep specialist because severe sleep disorders occur in up to 62.5% of persons with chronic fatigue syndrome, as compared to only 7% in the general population. Managing pain. Pain can be managed with medications or with non-pharmacological therapies, as you see here. Non-pharmacological therapies include rest, cold or hot packs, mineral baths or balneotherapy, liniments, massage, physical therapy, such as chiropractic acupuncture and electronic stimulation. Pharmacological therapy begins with the over-the-counter medications such as acetaminophen, paracetamol, NSAIDs, ibuprofen, and Coxibus. In the United States, 3 medications have been approved for neuropathic pain of chronic fatigue syndrome. These are pregabalin, duloxetine, and milnacipran. These are all available, I understand, in Japan, and to be approved for the use in chronic fatigue syndrome or fibromyalgia. They reduce pain modestly, but they have side effects such as nausea, sleepiness, and dizziness. Acute pain or severe pain may need to be addressed with narcotic medications such as tramadol, hydrocodone, oxycodone, or morphine. Although we try to avoid such medications because of the possible addiction effect and side effects such as drowsiness, hearing loss, and infertility. In addition to the four symptoms, chronic fatigue syndrome is accompanied by 4 typical characteristics. First, chronic fatigue syndrome is an exertional illness. If you exert too much, you get ill. On the other hand, if you rest too much, you get stiff and sore and deconditioned. So the lesson here is that if you do too much, you get sick. If you do too little, you get stiff and sore and ill. So the lesson is stay active, but not too active. The second, CFS, is a positional disorder. That is, the illness gets worse with standing, but is relieved by lying down. So the lesson here is that lying flat is frequently very, very important for our patients. Third, persons with CFS have unique hypersensitivities. They become sensitive to light, to sound, to chemicals and odors and fumes. And the temperature must be just right. If you get too cold, you suffer with shivering. And if you get too hot, you feel weak, maybe even faint. Lastly, persons with CFS do not tolerate stress. Stress may include something simple like a deadline or an appointment, or even confrontation with family or friends. Difficulty with paperwork or dealing with government regulations. So it is important to know that mental stress like reading and concentrating or using the computer are as exhausting as physical activities. And it's important to take frequent breaks from such activities. I normally recommend a rest period after 30 to 45 minutes of such stressful activities. This is perhaps the most important concept that I can report to you. It's important to rest frequently and to set limits on activity. So please consider at least 2 to 3 rest periods each day. They usually don't have to be long, just 10 to 30 minutes is sufficient. But because of the positional sensitivity, you must recline. It's important to be supine or semi-recumbent. And due to the stress intolerance, you must clear your mind. So in other words, if you're trying to rest, do not read, do not make plans, do not watch television, do not talk on the telephone. Just rest the mind. Rest the mind. You might hear from some sources, including your own doctor, that it's important to exercise aggressively. Actually, scientific evidence has shown that too much exercise will actually make your symptoms worse. Most persons with chronic fatigue syndrome tend to push and crash. That is, they exert too much and then are exhausted for hours to days afterwards. Persons who push and crash regularly will not get better because the body never has an opportunity to recover. The key to improvement is energy conservation. That is finding out what are the limits of your energy and then staying within those limits. Once again, it's important to stay active, but not too active. So in order to accomplish this, you may need help from family and friends, or you may need to delegate such activities as housekeeping or cooking, and you may have to lower your expectations of keeping house or working or exercising. This slide illustrates the fallacy of pushing and crashing. Let's suppose that you have 10 blocks of energy. This is 1 block of energy. If you exert too much for a day or two, like 4 blocks of energy, then there's very little energy left over for the next 2 days. So you may be very active for 2 days, but then must recuperate for 2 days. This type of activity is common, but prevents improvement from chronic fatigue syndrome. On the other hand, if you moderate activity for the first 2 days, say just 3 blocks of energy, then you will still have energy for the next 2 days. You can accomplish a lot more with this approach. Resting all the time is just as bad as pushing and crashing. No one ever gets better from just lying around all the time. But once again, despite what you may hear from other sources, even the sickest patients can do some activity. And it's important to attempt some activity if you expect to improve. Studies have shown that even CFS patients in wheelchairs can exercise as long as they do not overexert. That leads to the question, how much exertion is too much? Exercise studies in our laboratory and elsewhere have demonstrated at least 3 ways to set objective limits on your exertion. They would be aerobic interval activity, heart rate limitations, or using a pedometer. So we're going to look into each one of these very quickly. Using a technology called cardiopulmonary exercise testing, we're better able to understand why persons with chronic fatigue syndrome have low energy, reduced stamina, and malaise after exertion. One of the first lessons we learned was that persons with CFS cannot tolerate anaerobic activity. Anaerobic means that not enough oxygen gets from the heart and lungs to the muscles. The muscles then must use glucose instead of oxygen as a source of energy, and glucose metabolism produces toxic products such as lactic acid, organic acids, and other metabolites. Most persons with chronic fatigue syndrome can only exert 3 to 5 minutes before reaching the anaerobic threshold, and then they must rest for 5 minutes. We call this interval activity. So patients can do like you see on my hand, 3 to 5 minutes exertion, 5 minutes of rest. 3 to 5 minutes of exertion, 5 minutes of rest. And you can do as many intervals as feel comfortable. The problem with interval activity is that most people prefer not to vacuum, or to mow, or to exercise in short intervals. They like to keep going once they get started on something. So we developed the second technique, or heart rate limiting. The second lesson that we learned from doing these studies on the cardiopulmonary machine was that anaerobic threshold always occurs at the same heart rate. That's important. The anaerobic threshold always occurs at the same heart rate. Applying this principle, we can prevent relapses by limiting exertion so that the heart rate never exceeds this level. Cardiopulmonary exercise testing helps us determine the heart rate at the anaerobic threshold, but we can estimate the maximum heart rate by using this formula. A person's maximum predicted heart rate is 230 minus the age in years. Here's an example. 230 minus 50 means that a 50-year-old person would have a maximum predicted heart rate of 180. The heart rate for the anaerobic threshold occurs at 60% of that. So 0.6 times 180 means that this person, a 50-year-old individual, should not exceed 108 beats per minute. The last technique is by monitoring steps per day, a very simple actimeter, a very simple activity monitor. We know from experience that 1,000 steps per day is too little. So if you wear a pedometer and get only 1,000 steps, you need to do more activity. On the other hand, 5,000 steps per day is too much for most and could trigger a flare or a relapse. It's a very simple and inexpensive technique. Please keep in mind that so far I've been talking about recommendations for persons who have only moderate symptoms of chronic fatigue syndrome. I understand, however, that many Japanese patients are severely affected by this illness. They're mostly housebound, sometimes chair or bedbound. They may experience significant difficulty with all aspects of personal care or living independently. In addition, they are more likely to suffer from food and chemical sensitivities and may be extremely sensitive to light or sound or temperature. Some have severe neurological symptoms such as atypical seizures, swallowing or speech difficulties, muscular jerking, or profound weakness. We do not know why some patients are more severely affected than others, but many can be rehabilitated, but it takes a special effort. Home visits from the doctor or specialist or a telephone consultation are extremely helpful. Occupational therapy may improve the home environment with assistive devices, walkers, special computer stands, and ergonomic beds. Home physical therapy, such as range of motion or resistance against gravity, supine exercises, can be very, very helpful. It's important for these individuals to stay active also, although the limitations are greater. A home health aide or a caregiver for cooking, laundry, housekeeping, and shopping is very helpful, and they should be provided with balanced nutrition, healthy organic foods, pleasant activities, for example, writing or embroidery, knitting, watching nature, listening to music, listening to books on CD. And it's important to assure socialization as well. So brief visits from family or friends or using social media on the computer like Facebook can be very, very helpful to our severely ill. The doctors need to know that for severely ill patients, it's important to minimize medications and the supplements that they use, and that medications have to be prescribed in very low doses and titrated or increased very slowly. Stress management and grief or loss counseling can be helpful. Try to achieve something every day. That's the encouragement part here. And don't accept your current restrictions. In my office, we encourage our patients to improve 1% every week. So if you can talk yourself into saying, I'm going to try to improve myself by 1% every week, you can be 50% better in a year. And you have to expect lowered expectations for yourself